So what are the pathogenesis here? Number one, reduced contractility. What is the reduced? We have to see the systolic and diastolic as well. So reduced contractility means that the heart tissue is damaged. What happened to the heart tissue? Ischemia or infarction. Ischemia or infarction of the heart tissue. So here is a damage, ischemia or infarction of the right ventricle. So what would that do? That would reduce the contractility, and reduced contractility means reduced cardiac output. Here there is nothing with the lungs. Now, is this a systolic dysfunction or a diastolic dysfunction? It is a systolic dysfunction. Why? Because the heart, when it goes in systole, when it tries to contract, it cannot contract well. Remember that systolic dysfunction was also marked with an ejection fraction reduction, right? So systolic, we discussed it before, systolic dysfunction has a problem with reduced ejection fraction. Diastolic dysfunction, we'll talk about that in a second now. Diastolic dysfunction had normal or even increased ejection fraction, and we did that in detail before. Please listen to the left ventricular hypertrophy. I'll explain it if I get time here. Okay, so systolic dysfunction, reduced contractility, ischemic heart disease. How about reduced compliance? When can the ventricle be unable to expand? That is a diastolic dysfunction, right? What is the diastolic function of the heart? Expand and let the blood come in. Diastolic dysfunction means it cannot expand. Why would it not expand? Either there is a hypertrophy or there is cardiac myopathy, right? So when can you have the hypertrophy? That is the case where there is cor pulmonale, there is increased pressure in the lungs, increased resistance in the lung, that causes chronically increased pressure in the ventricles start becoming hypertrophied. So if this was a normal ventricle, now this has become hypertrophied ventricle. The ventricle that is hypertrophying against pressure is concentrically hypertrophied. The diameter of the sarcomere increase or the myocytes increase. Okay, so that is the reduced compliance in case of increased pulmonary hypertension. How about increased afterload? Can we increase the afterload on the heart? That is also the same thing. Increased pulmonary resistance will increase the afterload on the heart, or there is one more way, easier way. What is that? Pulmonary valve. If you stenose the valve, if you make this valve stenosed, will the blood get out easily? No. Will the right atria now have to press against it and contract against that, exert force? Yes. Will it become hypertrophied? Yes. So that also is pressure hypertrophy because it is exerting equal pressure, so that will be concentric hypertrophy causing diastolic dysfunction, right? So increased pulmonary hypertension or just pulmonary hypertension, pulmonary valve stenosis will cause the increased afterload. How about increased preload? How about if we increase the volume of blood coming into the heart? Now this is volume increase. This will be eccentric or concentric hypertrophy? Eccentric hypertrophy, right? Because the volume would stretch the muscle. So we have done that in the left heart. What will happen is that the sarcomeres will be increased in series. So if normally in a myocyte there are 3 sarcomeres in series that make a length, so this is one sarcomere and this is another and this is another, this is the normal heart, there will be one more sarcomere added in series, so that increases the length. Magic here. So this is called eccentric hypertrophy. So whenever there is volume overload, that will result in the eccentric hypertrophy because the heart has to dilate. So increase preload, how can we do that? Look, the same valve, pulmonary valve, make it incompetent, make it regurge. If it regurges, then the blood that is pumped out is going to fall back. that falling back of the blood will do what? Increase the preload, right? We're talking about the preload. How about this? If we have a regurg in the right atrium, yes, when you regurg to the right atrium, then that blood is going to turn back and fall in it again. So that would actually have systolic, that preload problem plus the afterload problem, both. How about if we move blood from the left side to the right side? Shunt, interventricular septal defects, that bring from the left to the right, it brings blood. That overloads the volume here. So at the end of the day, what we're trying to do is, if we overload the heart with the volume, right ventricle with the volume, then it would become dilated, and that will be the eccentric hypertrophy and diastolic dysfunction. What is this dysfunction in the case of eccentric hypertrophy? What is the problem in diastole? Well, heart has become bigger now. It is pooling more and more blood in it. So there are two problems with that increased pooling. One is it needs more energy, it needs more oxygen, it needs more strength, it needs more contractility to push that out. And that is not going to happen because this heart is either pushing out against some resistance, or it is damaged because of ischemia or infarction. So as the blood keeps staying in here, the tension keeps staying built up. That needs oxygen. And oxygen demand is not going to be met because it is poorly functioning heart. And this would just be a vicious cycle.